Good afternoon. I'm Dr. Gloria Cain. I'm with the Howard University School of Social Work, where I serve as an assistant professor, and I'm also a co investigator in the Department of Psychiatry for a study around opioid use and the use of medications in the community. And so this afternoon, we're going to talk about substance use and misuse. The pandemic has really changed the course and the trajectory of how we look at, alcohol and substance use disorders. And it's also increased the need for more, interventions that are, trauma informed, as well as the need to increase the number of professionals that are in the workforce. So this afternoon, we're just going to talk about, substance use and misuse. We're going to talk about, what a standard drink is. We're going to talk about some commonly used substances this afternoon. Thank you. And so, what is addiction? So, this is how we define addiction. We know that it's a chronic relapsing brain disease, which involves compulsive drug seeking and, use despite harmful consequences. And we know that drug use and alcohol use changes the brain and its structure. And sometimes these changes can be very long lasting. And we also know that, addiction is a very complex disorder and it involves the interplay of, biological, sociological, and psychological factors that kind of all work together and, affects, one's brain and one's decision making. And it also contributes to, chronic relapse as well. We also know that, substance use is multifactorial because it affects a number of systems in terms of our health systems, our family systems. It affects employment, it affects parenting, and it also has an impact, on the community. And a lot of the times these systems, kind of work together to kind of shape and form the behavior and patterns that a lot of individuals with substance misuse are challenged by. And it's not that these things operate in silos, but they all operate, together all at once. And so it lends to substance misuse being, multifactorial. So, extended use of, alcohol and drugs, can result in an individual developing dependence. It can also lead to chronic health conditions. And sometimes it also results in, overdose injuries and also overdose deaths. And so some risk factors that are associated with, addiction or substance misuse are family of origin, whether or not, there's a family history of use and abuse. Sometimes cultural factors can be a risk. And sometimes external factors such as, poverty, stress, single parenting, unemployment, divorce, and even exposure to trauma are, very strong risk factors, for substance use and or addiction. And so we also know that, peer influences and the availability of substances in the community, are risk factors, for substance use. So, one of the things that I would like to share with you is this card on what is a standard drink. A lot of the times when people are engaging in alcohol use, they don't necessarily know what a standard drink is. So we know that a 12-ounce can of beer, a 5-ounce glass of table wine, 1.5 ounces of brandy, 8 to 9 ounces of malt liquor, and 3 to 4 ounces of any types of fortified wine, and 1.5 ounces of spirits, which is equivalent to a shot glass, are all considered one standard drink. And so when we're thinking about, alcohol misuse and abuse, it's very important to understand what standard drinks are because some people who may drink more than what's recommended or more than what they intended to, a lot of the times don't know that, they may be drinking more because they are not necessarily familiar with the standard drink. And so here's an example of a standard drink, which is a Long Island iced tea. And some people may think, well, because I just ordered this one Long Island iced tea, I've only had one drink. But, the fact of the matter is that this is actually 5 drinks because each shot of alcohol increases, the level of alcohol that's in this drink. And so it brings it up to actually 5 drinks. So this is why it's important to make sure that persons understand, what a standard drink is. Okay. And so let's talk about at-risk drinking. The National Institute on Alcoholism and Alcohol Abuse, spent a lot of time over the years doing research to try to understand, like, what are these low-risk drinking guidelines so that, people prevent injury and illness if they're consuming alcohol. So based on their research and recommendations, men should have no more than 14 drinks per week and no more than 4 drinks per occasion. Women should have no more than 7 drinks per week and no more than 3 drinks per occasion. And with older adults, it's recommended that they have no more than 7 drinks in a week and no more than 3 drinks on one occasion. And if it's a woman and if she's pregnant, it's recommended that she refrains from any alcohol or substance use because of the uncertainties that medically can happen to the unborn baby. And so these are just some of the low risk drinking guidelines that are set forth by the National Alcohol Institute so that people are able to prevent, any injury, illness, or harms through drinking. And so some commonly used substances that we are very familiar with are, of course, alcohol. And yes, alcohol is a drug. A lot of people think that alcohol is separate from other illicit drugs, but alcohol is considered a drug. And sometimes it can result in, aggressive type behavior. And then we know that some stimulants are also associated with paranoid type behavior. And also individuals engaged in opioid seeking behavior can sometimes engage in violent like activities. So these are some of the commonly used substances that we often see in our clinical settings. So the Diagnostic and Statistical Manual of Mental Health Disorders, what we call the DSM-5, um, sets forth the diagnostic criteria for substance use disorder around 4 different domains. So the first domain is impaired control. The second domain is social impairment. The third is risky use, and the fourth is pharmacological criteria. So an individual that presents with a substance use disorder has to meet these 4 diagnostic criteria, and there are a number of different symptoms that are related or that you can find within these 4 diagnostic criteria. So I think there are over 11. And so when someone is diagnosed with a substance use disorder, um, based on the number of symptoms determines the level of severity. So we know that if an individual has 2 to 3 symptoms, they have mild substance use disorder. 4 to 5 symptoms means that they have moderate substance use disorder. And then for individuals that present with 6 or more symptoms, they have severe substance use disorder. And some of the symptoms that are associated with these substance use disorders is, craving, individuals wanting to stop or cut down on substance use but not being able to, taking substances in larger amounts, over a period of time than what you necessarily intended to, neglecting parts of your life, neglecting family and friends and responsibilities, continuing to use even though it causes problems within the family, employment, school and relationships, and also using substances even when it puts you at risk, or puts you in danger. So there are a lot of different models and theories as to why people suffer from addiction disorders or substance misuse. And so as you can see here on the left, we have the moral model, the disease model, the psychological model, sociocultural, the biological model, the social learning model, and the biopsychosocial model. And we'll talk about some of those. So first we want to start out, with the moral model. So the moral model of addiction believes that it's a moral failing, that an individual, has a character flaw. Some people who believe in the moral model think that, it's a consequence of someone's, personal choice. In the past, some legal and religious institutions, have, adopted and, believed in the moral model. A lot of the times the moral model is influenced politically. And we also know that this moral model can contribute to stigma and often present and pose barriers to people actually getting treatment because they're made to feel as if, it's their fault, they failed because, they suffer, from an addiction disorder, rather than being treated with, respect, worth, and dignity, just like somebody presents for any other health issue or disorder. And so we also have this social cultural perspective. And it kind of posits that, addiction is the result of external factors, meaning factors outside of the individual, such as, family, friends, peers, institutions, and the environment. And so we also have the psychodynamic model that talks about, addiction being the result of an underlying psychological problem, that people use addiction as a way of self medicating these psychological and emotional issues. It's believed that addiction is a maladaptive coping strategy. And when underlying psychological issues, are addressed, the addiction will be resolved. And so we have this biological perspective. And with the biological perspective, it's the belief that, genetics and the environment, kind of interplay and result in this gene environment interaction, which may result or lead to someone having, an addiction or substance misuse disorder. But according to Dr. Kudor Snell, former dean and current full professor at the Howard University School of Social Work, who has a lot of experience in working with patients with genetic risk to alcoholism. Dr. Snell believes that this genetic risk is not a patient's destiny, that just because you're the child of an alcoholic parent or a parent with substance use, it's not genes alone that condemn a person to a lifelong battle with alcoholism or any addiction. And we have to always keep in mind that when working with clients and working with patients that have substance use disorders that report a family history, it doesn't necessarily mean that it's their destiny as well. Okay. So we also know that stigma has a very important role in substance use. And stigma is defined as a mark of disgrace or infamy or stain reproach, as on one's reputation. And so, stigma also remains the biggest barrier to addiction treatment that's faced by, patients and clients. And, we realized that, during the pandemic, that stigma, plays a significant role in the management and treatment of alcohol and substance misuse, especially in, marginalized communities. And so we also realize that it's a barrier for people wanting to, seek out treatment or even want to go to treatment, because of the concerns that, the healthcare provider may think less of them and think that, they have some type of character flaw because they are showing up or presenting, with an alcohol, or substance use disorder. So we know that stigma really plays a strong role in the community in terms of, individuals' willingness to get treatment. And then some actually have, their own lived experience and where they've been stigmatized because of alcohol, or substance use. And so just a couple of facts about stigma as it relates to substance use disorder. It's probably one of the most stigmatized conditions, in the United States and also in the world. And so, healthcare providers might treat patients or clients that present with substance use disorders, very differently. And then people with substance use disorders who expect or experience stigma, they have poor health outcomes, because of those experiences. And, we no longer want stigma, to be a barrier in people being motivated, to get treatment or not. We want to make sure that, that we address stigma, that we educate our clients and patients about it so that it doesn't serve as a barrier for them accessing treatment and help. And then the burden of stigma, upon diagnosis of substance use disorder. really has a lot of control over, a patient's willingness to seek help or treatment. And it's also, something that the person, feels as if, they're, taking the blame and the fault for a disorder that, is rooted in a lot of different factors. And so we still have to make sure that we help our clients and our patients understand that they do not have to take on the burden of stigma. Okay, and so the role of prevention for substance use providers, and particularly in dealing with stigma, we want to make sure that we work very hard to, advocate for those that have a substance use disorder, in these different health systems, in these community-based programs. We want to challenge providers and communities to be aware of, biases, even if they're intentional. And we also want to make sure that when we're referring to people who have alcohol and substance use disorders, that we want to use language that is appropriate. We do not want to use language that promotes further harms, or use language that will have an impact, on an individual not seeking treatment. We want to make sure we remove any labels, and we also want to make sure that we use person first language. And so when we're using, you know, language that's appropriate, we want to make sure that terms that are often used that promote stigma, are avoided at all costs. And so some of these terms are words like addict, junkie, user, alcoholic, and even other terms such as bad mother, bad father, the terms, clean and dirty, all are all terms which a lot of the times can promote stigma and have an impact on a patient's willingness to engage, in substance use treatment or care. And a lot of the times it can have an impact on the provider patient, relationship. So we want to be mindful, of the language, that we're using, and make sure that we promote language that also promotes change. And so some terms that are more appropriate to use, especially when talking about substance use disorder and to prevent stigma, are, we have a patient or we have a consumer, with a substance use disorder, or you can just say we have a patient that, has a negative, urine test or a positive urine test. And rather than calling somebody a recovering addict, you can say, well, we have a patient that is, in recovery. And so we think that these terms, help to reduce stigma and also help people that present with substance use disorders to feel more comfortable, in treatment, and to be able to trust, their provider. Okay. And just a couple of reminders. We want to consider, alcohol, substance use, just like any other type of disorder, such as diabetes, depression, and hypertension. I remember someone saying, well, when I go to my doctor, I want to be able to say, hey, I have a substance abuse disorder. Just like somebody next to me may say, hey, I'm here, to get my diabetes treatment or my treatment for hypertension treated. Okay. And we also want to make sure that just as chronic diseases and other chronic health disorders, are managed well, that substance use is also managed, well, and is treated, as equally as any other type of disorder. And so successful treatment for substance use means that, the person is in recovery. It doesn't necessarily mean that it's cured, but they're in recovery and that, treatment is possible and they can live a very long life. Okay. So, one of the things that often occurs with substance misuse are also co occurring disorders. And basically, what a co occurring disorder means is that a person has a substance use disorder as well as a mental health condition as well. And a lot of the time, substance use treatment can be challenging because the co occurring disorder is not treated simultaneously along with the substance use. And so we know this leads to, more treatment failures and cost. It can also contribute to people, having chronic relapse. It can contribute to people being rehospitalized, time and time and time again. It can lead to multiple ER visits. It also makes people extremely vulnerable to violence and the potential for suicide, homelessness, and also arrest. And we know that when co-occurring disorders are not treated along with substance use disorders, it can lead to more illness and earlier deaths. And sometimes people can be very resistant to treatment, if you're only treating one side. So it's very important that we treat these co-occurring disorders together, very simultaneously. In the past, it was the, I guess, clinical approach to either treat the substance use disorder and then treat the mental health disorder. But we realize over time that alcohol and substance use co-occur, with other types of, mental health disorders. And some of the co-occurring disorders that are very common amongst people with substance use disorder are, depression, anxiety, PTSD, and trauma. Okay. And one of the things that we want to consider when thinking about how to best provide treatment for individuals with substance use disorder, there are a lot of options out there, and we have to make sure that our patients and our clients, are a very good fit for the different types of treatments that are available. So we know that no single treatment is appropriate for all individuals. We also know that, effective treatment attends to multiple needs of the individual and not just, their drug use. And we also have to understand that, treatment must address all the medical issues and concerns that clients and patients present with, any psychological concerns that they present with, any social related concerns, which also include vocational issues. And then oftentimes we have clients and patients, that present, with legal problems. And so, given that clients with substance use disorders have a lot of different service needs, we want to make sure that the treatments that we're thinking about are a good fit in terms of being able to service, all of these different types of service needs. And, we just don't want to treat the substance use disorder and not treat, the mental health disorder, housing, legal problems, vocation, nutrition. We want to make sure that all of those things, are a part of the plan because, as I mentioned earlier, substance use is a multifactorial disorder, and it affects, just about every domain, in our clients' lives. And so we want to make sure that all of those things, are considered and that we're just not treating the substance use disorder, in a silo, all by itself. Okay. And so the American Society of Addiction Medicine provides recommendations for, the level of care that should think about when treating substance use disorders. The first thing we want to do is think about, early intervention. For a long time, people would not get help or be seen or treated for a substance use disorder until they hit rock bottom. And so now we know that, early intervention helps and it works, and people no longer have to hit rock bottom in order to be able to access, treatment or to be able to access a provider. And there are a lot of effective, interventions that work to help people early on to be able to, interrupt, this process of becoming dependent, on alcohol and drugs. So early intervention efforts, are very effective and very helpful in helping people to, avoid the development, of a serious alcohol or substance use disorder. We have intensive outpatient treatment programs and where people are able to, get treatment through a provider that's community based, in their community. to be able to see them anywhere from, 2 to 3 times a week. And usually these types of programs are very structured, and people are able to engage not only in counseling and behavioral health interventions, but there are also interventions that are around, making other types of behavioral changes, or helping them to, make behavioral choices that are, good for their health as in order to maintain and manage, their substance use disorder. And also, these programs provide vocational services, employment, and they also provide help and assistance, with housing. And so we also have the intensive outpatient and partial hospitalization. And then we still have the use of, residential and inpatient treatment programs for individuals who may need more than just outpatient treatment and help. These individuals could benefit from these structured residential programs, and where they're usually staffed by a number of different behavioral health professionals, including social workers, psychologists, psychiatrists, and the use of peers. And these peers are individuals that have lived experience with alcohol and substance use, and sometimes mental health, and they've gone through a lot of extensive training to be able to work in these settings to help patients understand and to navigate, systems of care, when they are getting help and assistance for substance use. And then we have medically managed intensive, inpatient treatment, and where you have providers that are located in programs that help people, who may be hospitalized, but they are being treated, from a medical model. And then we have opioid maintenance therapy, and then these are the use of medications to help people to manage and to help people to, um, manage opioid use disorders. Some of these medications that, you may be familiar with are buprenorphine or Suboxone, Vivitrol, and methadone. And so these are some of the levels of care that are available, that are recommended by the American Society of Addiction Medicine, to help individuals to manage, any type of, alcohol or substance use disorder that they may have. And remember, from the previous slide, I indicated that we have to make sure that when choosing and selecting these programs, that it's a very good fit, for our clients, because every level of treatment, every level of care may not necessarily work for every client. Like if you have a, intensive outpatient treatment, but you have a client that has problems with compliance, you may want to think about a program that is residential so that they can have more of a structured environment, to help them, with compliance and an environment that will support them as they're trying to manage, being compliant as they are partaking, in these different types of, treatment methods. Okay. And so some things that we should consider next in terms of, treatment. When developing a treatment plan, we really need to be very specific and clear about goals for our clients. And a lot of the times, developing long-term goals may not necessarily be suitable for a client who's, kind of early on in their treatment, or a client who is dealing with substance use and also dealing with a lot of other health issues and other health determinants. So sometimes it's okay for the goals to be short term. And then a lot of the times, those short term goals, if they're achieved, then they can lead to developing, long term goals. Um, and then also knowing what the treatment, priorities are. And, as we talked about earlier, clients present with a number of issues that are connected to a lot of different systems. And so we have to prioritize, like, what's the most important issue, or what are the top priorities that we need to address, in our treatment plan, or what are the top priorities that need to happen or to be considered, when helping clients to, navigate, the treatment plan. And then also knowing what type of counseling and what type of education is needed. And a lot of that will depend on your assessment of the client, where they are in terms of their, cognitive skills, and where they are in terms of, even their physical health, and even where they're located, because you want to make sure that, if you are incorporating counseling and education, are they located in the area where they can access those services? And then you want to determine, well, will this client benefit from going through detox? Is detox, also necessary to get this client on the path, to be able to engage in treatment? And also, you want to make sure that you consider all types of recovery supports, including those self-help groups. And you want to make sure that your treatment plans are very comprehensive, and that also you allow your client to have a part, in the treatment planning process. And, many moons ago, clients weren't allowed to, have a say or have any type of input on the type of treatment that they wanted, or any input on what they thought would actually work for them. But we've done a lot of work to change that narrative. And we want to make sure that we always include our clients, in the process, whether it's a client that's mandated or, it's a mandatory, treatment agreement. Clients still have the right to, have a say in the type of treatment that they would consider, and in the type of treatment that would work well for them. So we want to make sure that we include them in the process. And also, clients are very familiar with the environments that they live in. And so they kind of know, like, this treatment might work for me, and this treatment, may be a little challenging, or, this treatment seems like, it's a good fit because I know that my environment will support this type of treatment, and my environment will help me to be successful, in this particular treatment, program. And so just some special considerations. We talked about working with mandated or clients that are mandatory. And we just want to, keep in mind that just because a client is court ordered, whether they're on probation, parole, or however they are re-entering, society, we still want to treat them with respect, dignity and self-worth. And we also want to understand that a lot of the times these clients are coming from, systems and that have historically, marginalized, brown and black people. And we also want to make sure that a lot of the times, these systems, have not necessarily been challenged to make sure that, the black and brown people are able to access, services, not only for court ordered treatment, but for other types of issues, as well as it relates to substance use. And then we also know that sometimes people are externally motivated to get help for alcohol and substance use because of family pressure. Sometimes it's, sanctioned by an employer. And then sometimes, the motivation to get treatment also stems from, clients or patients being told that they have medical conditions or consequences that can be made worse by alcohol and substance use. So these are just some special considerations that we should think about. And, just to make sure that when we're working with clients, from these different systems, that we still treat them with kindness, respect, dignity. And these are the type of skills that, no matter if you are a clinician, a social worker, a psychologist, psychiatrist, or even if you're clergy, are the type of skills and values that can be applied in any discipline and in any profession than working with those with alcohol or substance use disorders. Right. And then we also know that self-help groups have been very helpful in providing support for people with alcohol or substance use. And self-help groups are not, clinical in nature, but they serve as a support to people who are trying to maintain their, sobriety. And some of these groups that we are familiar with are like 12-step groups, such as, AA, Alcoholics Anonymous, and Narcotics Anonymous. And a lot of these groups encourage, participation, during meetings and even after meetings. They encourage, individuals to, advocate for themselves. And, these meetings are available, 24 hours a day. They're available all over the world and all over the country. And even when individuals travel to other states, they can always locate, a meeting to go to support themselves, even when they're on travel. And then we also know that a lot of the times, alcohol is used at a lot of professional meetings, with different types of, professional work groups. And so a lot of organizations actually have NA and AA meetings because they are able to support the members, who may struggle with alcohol or substance use. And they provide these meetings, throughout, the conference week and at the conference sites. So these people can continue to feel supported and to help to deal with some of the triggers that may present, when you're in these professional meetings or conferences and where, alcohol is served, and alcohol, is used. And, there are meetings that are open and there are some meetings that are closed. A lot of the open meetings, they do not, discriminate against, persons coming in and being able to share. However, some closed meetings may be a little bit more discriminate about, members who, can attend. And then we know that for some of these closed groups, some have historically excluded people, because of race. Um, and then many years ago, some people felt that, well, if I go to an NA or AA meeting, um, and if I'm in on the AA side, I don't want someone with a drug problem, to come into my AA meetings because we're not drug addicts. We don't use drugs. And then some people in A have felt the same about folks with alcohol. Well, we don't want people with alcohol problems, coming into, our meetings. And there are a lot of meetings and support groups that actually support people on both ends who either have alcohol or substance use, or even, folks that have both. So you have to be very careful when referring clients for self-help groups because some may be open and some may be closed, but they're located all over the world. They operate and function, 24 hours a day. And sometimes I think, wow, if we had self help groups that operated for a number of disorders other than substance use, that would really be amazing. And so, just some myths about 12-step groups. Some people believe that only AA can treat people with alcohol use disorders, or only a recovering individual can treat like an addict. Some people think that 12 step groups are, intolerant of prescription medications, and that some groups are more effective than individual supports, because of, confrontation. And so a lot of the 12 step groups are actually run by people that we consider peers. And these are people, with lived experience. And so, each group doesn't necessarily operate the same. Some people think, well, if you don't abide by, like Christian doctrine or principles, you can't attend AA, but AA welcomes, people of all different race, ethnicities, religious beliefs. Um, so it's a very open, group that is facilitated by peers, people with lived experience, and they also have sponsors. So they have a process in where people can actually obtain a sponsor who might be able to help them and support them, through their recovery process. So, they're very effective. They're not used to replace treatment, but they're used to support people that are in treatment and people who are trying to maintain their recovery and sobriety. And so, people who are in active substance use attend, AA and NA groups. So, it's a process and it's a concept that's very open, very flexible, and they really accept people, as they are. Okay, and just a couple of facts about NA and AA groups. As I mentioned earlier, they're available 7 days a week, 24 hours a day. They work with all professionals. Um, and their primary treatment modality, is fellowship. They don't have the DSM diagnosis available. They're not diagnosing anyone. They promote safety and acceptance. And they offer a safe environment for people to tell their truth, and to explain their story. Okay. And so one of the things I also wanted to talk about, since we are talking about, effective treatment and interventions, is the use of medications. And, we have a lot of medications that are out here available, to treat substance use disorder. I think some of the concerns that we may have in the community about these medications is that they haven't necessarily always been available, especially in Black and Brown communities. But, some of the things that we should consider is that, when we're thinking about medications for a lot of our clients, um, you know, we need to, be mindful of whether or not, medication assisted treatment or medications for the use of opioid use disorders, are appropriate. Some people think, well, in terms of medication, nothing works. Psychosocial interventions are not effective, or, for abstinence or reducing drinking. I've got to stop, an immediate serious need to stop or, reduce, my alcohol or substance use. And then some people think about it in terms of, just help me stop. So this is when the patient wants to stop or reduce drinking, but, they're not interested or able to start, counseling or even engage in any type of self-help. Some people are like, well, thanks for the meds. I'll get it under control. I'm unable to accept the idea of, a chronic disease. And so, these medications can be very effective. We've actually observed and seen people that have been prescribed medication for substance use be able to work, be able to take care of their families. They've been able to live, functional lives, and often able to present as, model citizens, in their communities. And, whether or not someone decides to use medications, it's their own personal choice. We can't force them, to take medications. However, we can provide them with education and information that would allow them to make an informed decision as to whether or not medication assisted treatment, will work well for them. Okay. And so we know that by recommending medications, we found it to reduce, alcohol use, which, can lead to abstinence. It helps people to stay motivated, to stay abstinent from, alcohol or substance use. And sometimes it can prevent severe consequences, such as relapse. And it also allows individuals to learn new coping skills. It also helps to establish, relationships. It allows people to be able to go to work. But, as I indicated earlier, we have to make sure that the person is a good fit. Okay. Okay. And so I also want to talk about harm reduction. One of the things that we know is that we can't make people stop using alcohol and drugs overnight. But one of the things that we can do is that while people are in the process of recovering or in the process of even thinking about it, we can attempt to reduce the adverse consequences of alcohol or drug use, among persons who are continuing to use. And so we do this by this harm reduction. And so we help people to focus on positive changes without any stigma. And we help these individuals to work through, being discriminated against. We help them to work through judgment. And we also help them to work through their own concerns, and feelings about stopping, or cutting down. And we acknowledge that, it's difficult to stop or cut down overnight. But one of the things that we can do is help you to reduce or prevent further harms, and also reduce and prevent, further harms, in the community. Okay. And some of our goals for, harm reduction are to, reduce the harm of, drug policy and laws. We also want to make sure that we reduce the amount of deaths and overdose from substance use. And we also want to make sure that we minimize healthcare costs, due to the death, overdose, and disease. And we also want to make sure that we keep individuals alive and that we encourage, positive lifestyle changes. And we also want to make sure that we reduce and prevent the transmission, of disease as a result of substance using behavior. Okay. All right. And so this concludes our talk on, substance use and misuse. And I hope that, the information that you obtained this afternoon will help you, whether you're a clinician, whether you are a lay community, whether you're, in the faith community, to kind of think about where we are in terms of, how alcohol and substance use looks in our community. Think about what treatment innovations, are out there, or even how treatment can be improved. Because remember, just like any other health disorder, alcohol and substance use changes over time. Drug use styles and trends, change over time. And so therefore our treatment, methodologies and interventions also have to change over time as well. And once again, I thank you all for joining us this afternoon. And if you would like further information, my email address and my contact number is located here on the slide. And the Howard University School of Social Work thanks you so much for your support and your attendance this afternoon. Thank you.